Right, so got it. So we want to welcome everyone to the Right Care Initiative Virtual University of Best Practices. The meeting is starting now. We'll give a minute for everyone to actually log into the system. We have, as people file in, we'll allow you for that. I'm Dr. Baumer, and we want to welcome you on behalf of the leadership of the Right Care Initiative. A couple of things to remind you. During the program, we ask participants to potentially click on to mute so that the speakers will be unimpeded in their presentation. The second thing is that we do have CME credits for this. And if you look on the left side, you see that by, by selecting the surveymonkey.com link that is shown there, you can get on to the SurveyMonkey, which provides the CME credits for the program. If you have any problems, call Alyssa, and her email is there as well for that. And as we start out, we certainly want to thank the sponsors for Right Care Initiative. These supporters are important to provide the background funding that allows the Right Care Initiative to have its success in California and to continue the success, because we all realize we have done a great job. Today is actually the 10th birthday for Right Care for San Diego, for the program there, which was founded initially by Hattie and Tony DeMaria. We celebrate the success and the birthday of that today, and we just had a long presentation with San Diego with a lot of national leaders to celebrate that. So we want to congratulate those and then thank the sponsors. Why do we need those sponsors? Because we still have a lot of work to do. We talked about lowering the risk of cardiovascular events, especially in San Diego, by 20 or 30%. But that leaves us with a residual 70 or 80% of cardiovascular events, as our goal is to try to get those eventually down to zero. So we still have a big job ahead of us, and that's the program that we have today. Next slide. So Hattie was the initial founder, and actually Tony DeMaria had a good comment about Hattie today, that she was the dog on the bone intensive effort to get this program started. And it was a good an analogy of how her efforts and persistent efforts led to the success of the program. Next slide. So the program for Right Care, as you know, has goals, and those have focused on 3 types of goals: blood pressure control, diabetes control, and cholesterol control at the 80% or higher level. And we've succeeded in that in many of the areas, and we have data to show that that actually reduces cardiovascular events, heart attacks, and even deaths in the programs where that is there. Under the program, or the motto of Warren Barnes, that we compete against disease and not each other, it allows this collaboration to be much more effective and successful. Next slide. So the program today is shown here. We have 2 great speakers. One is deploying tech to improve diagnostics, treatments, and outcomes. That's going to be an innovative way and really a back to the future type of situation, where we can look at the latest and best in diagnostics and how that's going to improve it. We'll then talk about the pharmacists and their role in employing this. And to start the program, what I'd like to do is introduce Bob Kaplan, who was literally responsible for organizing today's program. has been one of the original co-founders of Right Care Initiative, has stayed with the program for these 10 years. And we're happy to have Bob, who will be introducing our speakers today. Robert.
Thanks so much, Bill and Hattie and others. So we should probably move on to Dr. Chen's presentation. Steve Chen has been a very loyal contributor to Right Care for quite some time. He is a professor and associate dean for clinical affairs at the USC School of Pharmacy. And he's also the William and Josephine Hares Chair of Community Pharmacy. By the way, Steve is a Trojan through and through. I have to preface this by saying that many of you know that I come from a UCLA family, that my father went to UCLA. Actually, my grandfather late in life went back to UCLA and took classes. One of my kids is a graduate from UCLA, and I was a faculty member at UCLA. And so, it's always hard for us to acknowledge very unusual talent across town. But in fact, Steve Chen is an example of just an exceptional faculty member. He received an honorary fellowship from the California Society of Healthcare Pharmacists and the American Society for Health Systems Pharmacists and the National Association of Practitioners. I won't go through all of the awards that Steve's won, but suffice it to say that just about every imaginable award in pharmacy he has received. These include awards from the American Pharmacists Association, a Pinnacle Award, which he's won 3 separate times. He has received the Pinnacle Award for Individual and Career Achievement. In 2015, he received the American Heart Association Multicultural Incentives Award, the Schweitzer Fellowship Leadership Award, and on and on and on. I do have to say that Steve has been recognized for his work that he's done with CMS, a project in 2016, which has estimated to have contributed to about 80,007 lives saved and 2.1 million fewer patients harmed, and about $19.8 billion in cost savings. Now, I do have to say that Steve has 2 daughters that he mentioned to me. And one of them is a college senior, guess where, at USC. And the second daughter has just graduated from high school, and guess where she's going to go to college, USC. And Steve mentioned that when the first daughter graduated high school and left home, then they got a dog. And now it looks like the second daughter's leaving home. So perhaps Steve and his wife are actually on the hunt for the second dog. And I'm sure that both of them will get those little USC dog sweaters. So Steve, thanks so much for doing this. And we look forward to hearing your comments today.
Bob, thanks for the introduction. I have to say that I also have many relatives that graduated from UCLA. So we don't talk school politics very much. Can I get access to slide sharing, please? Okay, thank you. While this is setting up, and I'm going to turn on my sound sharing, which is on right now. Let me just say that I first heard Dr. Shah speak as he was leaving Kaiser, Southern California, and going to Stanford. And I'm sure he remembers this. Our mutual friend, Dr. Michael Hochman from USC, had invited him to speak for the Gare Center. And that it was one of the best talks, just like you heard just now, one of the best presentations I've ever heard. And he didn't use one slide. He just spoke. And I was riveted. I mean, Dr. Shah can tell a story, and it was an amazing story about quality outcomes. And I ever since that day, I've spoken about what an amazing speaker he is, and to many people, including this group. And now I have to follow him. So I should have switched the order and gone first. I really regret that I didn't jump on that opportunity. So, I am not going to talk about high tech. I'm certainly not anywhere near the kind of knowledge in that area that Dr. Shah is, but I am talking about a common theme. And I think that's bringing care to patients. I really like your term democratize. I think it's so important that we get patients wherever they are, whatever socioeconomic status they are, access to the tools that they need to get the help that they need. And this is important because patients who leave their health systems, who leave their hospitals and go into the community are in the wild, wild west, right? It's how much control, how much tracking, how much knowledge do we have about what's going on? So part of the theme I'll talk about today is where pharmacists can fill that gap, that void. The other is I am very much a beneficiary of federated learning. I would have to say that Waze has prevented me from getting a ticket from driving many, many, many times. So I think it's an amazing technology. So this is where I'm going with this presentation. I'm going to talk a little about the unmet need that pharmacists are able to fill in healthcare. What is comprehensive medication management? Some of the evidence behind it, including our own work, all that leading up to the California Right Meds Collaborative and aligned state initiatives. Now, I know I've spoken to many of you now, probably 3 or 4 times. So forgive me if I repeat some of the background, but as Hattie reminded me, many people are new to this meeting. So I am going to cover it, level set at least what I need to. So this infographic that we reproduced with the California Department of Public Health attempts to just put in a picture, what is the impact of medication-related harm caused by not being able to optimize drug therapy? Now, there are some of the things that you probably expect. Side effects that harm or kill people, frankly, fourth leading cause of death in the US. But it's more than that. It's also about medications that are not being selected optimally, dosed optimally, adjusted, or even in many cases, indications that are not being treated. That amounts to over 500 billion with a B dollars in wasted money. That's about 16% of all healthcare costs. So this is not a small amount that's being attributed to suboptimal medication therapy. It accounts for 3/4 of hospital readmissions. And at the end of the day, at least half of all prescription drugs are taken improperly. That's a big number. How do we expect to get evidence-based therapies to do what we know they can do if we can't get patients to take the right medications? And I think one solution I hear often when I'm in quality improvement meetings or strategy meetings is let's get more information to the physicians, especially on the primary care side. Let's make sure they have all the knowledge that they need to optimally use prescribed medications. And that could work, except physicians are, especially in the primary care setting, are really busy. I don't know if you've noticed this. According to statistics in a couple of different studies, it's anywhere from 17 to 20 hours a day that your typical primary care physician needs to get all the essential work they need to get done. So you have less people going into primary care in medicine, and you have more people leaving primary care in medicine. So there's a dire shortage and really very little time for physicians to take care of all these medication-related needs comprehensively. And then you add to that on the pharmacy side. I don't know if you just saw this, but I welcome innovation in any part of healthcare that improves safety, access, and that's what things like Amazon Pharmacy are doing, right? They're taking their model and translating that into access to medications. That's great. Here they're now offering 6 months of prescription drugs for common chronic diseases for $6, right? So I can tell you that there are no pharmacies out there that have any interest in competing with that kind of value proposition. But what I want you all to keep in mind is this is for patients who it would make sense, right? There are plenty of older patients, there are plenty of underserved patients where this really doesn't work for them. And they actually need and would benefit from a pharmacist closely monitoring and working with them to ensure that the medications are working correctly. Add technology to that equation, and the practice of pharmacy, especially in the community, is changing very, very, very quickly. And pharmacy is well aware of this. We train pharmacists not to be producers of a product, but providers of a service. And I'll talk about that a little bit more. Maybe some other examples of kind of the in plain sight that I'm trying to describe here. I'm on a outpatient quality improvement committee for the American Heart Association, focusing on evidence-based treatments. And they recently shared the results of this survey from their site recognition participants pertaining to, in this case, the SGLT2 inhibitors and the GLP-1 agonists. They're finding that there is a high underutilization of these drugs. And if you look at the results of this survey, just about everything that is identified as a barrier is what pharmacists have been doing for decades. Dr. Shah and his leadership in Kaiser Southern California, I think, knows this better than anybody else. Kaiser has embraced the role of pharmacists providing medication management since the 80s and have done very well in terms of evidence-based therapy utilization. So you can see some of the examples here. PCP is not comfortable with these drugs, not having endocrinologists make decisions, a long time to see endocrinologists. The point in having pharmacists in this space to initiate, to adjust, to monitor these evidence-based therapies is that you don't need the specialist necessarily for that purpose. Now, certainly you need the specialist when the issues are beyond the scope of just pure med management, but the pharmacist can be very effective at ensuring that the patients are on the right therapies. Fears like insulin, all of these things are things that pharmacists deal with all the time, as are these as well. So it just goes on and on. Bottom line is the issues that were brought up in the survey were almost all related to medication management. And as the only pharmacist on this committee, I was so excited to share with this group this decades of work that pharmacists have had in this space in addressing this very issue they were identifying. As a result, this committee is considering a subcommittee that will be focusing on increasing awareness of the pharmacist work in the space and opportunities for health systems to partner with pharmacy. So moving along after covering some of the needs, what is CMM and what's some of the evidence? In a very simplistic way, comprehensive medication management is a standard of care. It's about choosing the right medication, giving the vast array of medications available, ensuring that the dose of medication isn't so low that it does nothing or so high it causes toxicity. I think a simple example of this, which we see all the time, are antidepressants. They're often given at doses, particularly in primary care settings, that are not effective at treating depression, and they continue indefinitely at those doses. We've audited many health plans and systems and found that to be true. We ensure that the medications are safe given comorbidities, drug disease interactions, and that patients can use the devices that they're given to administer their drugs. Don't know if you'll be surprised at this, but patients may understand how to use a medication-related device or administer insulin the moment they leave your office. Give them a few months and many steps are missed or forgotten completely. And last but not least, we make sure the drugs that they're receiving are affordable to the patient. Now, all of this is under the umbrella of a few other critical elements. The patients are followed until they reach treatment goal. This work is done collaboratively with physicians. This isn't a pharmacist doing things completely separately from the physician. And in the end, it's comprehensive. That means all medications, all conditions are considered. And I've practiced in this capacity, by the way, for 25 plus years in the VA setting in Beverly Hills and then on Skid Row in downtown Los Angeles. Now, for many physicians on this call in particular, I'm sure these are questions that you have in mind. And I initially took this out of the presentation because, as I said, this is probably the fourth time I've spoken to this group. Hattie reminded me that some people are very new to this idea of pharmacists on the care team. So I'm going to address these. I think they're really important to think about. The questions we sometimes get when we, promote this to medical entities is, wait a minute, aren't pharmacists trying to practice medicine without a medical degree? I'm trying to make it very clear, no, that absolutely not. The 4-year Doctor of Pharmacy program is heavily focused on optimization of medication therapy. Pharmacists are targeting drug-related problems for patients that are already diagnosed. We are not in diagnostic business. I'll be very clear about that. There's plenty of need to optimize medications. We're not on the diagnosing side of it. There are general and specialty residencies for pharmacies, up to 2-3 years now, and counting. There's fellowship training opportunities. We have board certification in general and specialty areas as well. Many are listed here on this slide. And in some states, you have advanced practice licensure, such as in California, where you have the advanced practice pharmacy license. So it's a pretty heavily regulated profession. And I guarantee you, pharmacists are the only people that are excited to see this, right? I know every physician, every nurse practitioner PA out there, if a patient brought this in, you would not be happy, right? This would cause some mild depression in its own. This was a real case of a patient who brought in almost 100 bottles of medications after the pharmacist convinced the patient to do so. Wasn't taking half of them, by the way. And so maybe some of the obvious questions are, well, why did you tell your healthcare team that you were taking your medications? And the answer was, well, I didn't want to, let my physician know that I wasn't doing what he was telling me to. So, why didn't you do it? Well, I was afraid of side effects. Okay. Then why did you keep filling your medications? The answer was, I was part of a auto refill pharmacy that kept sending these medications to me. So my point is that automatically refilling drugs, counting refill dates and calculating proportion of days covered, those don't always guarantee that patients are actually taking their medications. What about this one? Well, gee, what you're saying, Steve, it sounds like pharmacists are really prescribing, and that's going to fragment care. You have somebody else now meddling with my medications. That doesn't sound like it makes any sense. Well, just to be very clear, pharmacists are not federally recognized as healthcare providers. So by necessity, pharmacists have always been highly collaborative. We can't do anything independently, bottom line. And the way the legal requirements are set up by the boards of pharmacy, in order for pharmacists to provide any clinical services, there are all kinds of standards for the frequency and timeliness of communication and the agreements that happen with the health system. So it's really not possible to fragment care because there's always constant and consistent communication between the pharmacist and the healthcare team. And what happens as a result is patients end up getting more appropriate and consistent referrals that happen to between the healthcare team and pharmacy for both health and support services. And that's really important. What I teach to pharmacists is, you're doing a good job in comprehensive medication management if you feel like you're part a care coordinator or part of social worker. Because if you're not doing those things, you're not going to be effective at helping your patients get the treatment goal. And then the last point I want to make is that patients, when they experience having a pharmacist on the care team, we have data to support this from our work, their level of satisfaction with healthcare in general increases. Whether that's rating their physicians or the team as a whole, and physicians are happier. And I'm going to share that data with you later on. So this is such a simple, quick timeline. Again, having pharmacists involved in the care team happened as late in the 60s with the health services, went into the VA, Kaiser and other PBMs and med groups started picking it up. Safety net settings and retail pharmacy in the early 2000s. HRSA started a collaborative that I was a part of in 2010s, focusing on how do we expand pharmacists in this collaborative setup. And CMS then got wind of it. And if you look at CMS's incentivized programs, almost all of them have an opportunity, and really, I would say more of a need to add pharmacists to the care team to optimize medication therapy. And that was intentional. So in terms of evidence, there's plenty of evidence of guidance from more non-pharmacy entities than pharmacy entities that talk about the value of pharmacists on the care team, provide solid studies to back it up, and then give you some ideas and guidance as to how to make it happen. So I'm not going to go into these, but I just want to let you know that there are these types of resources available that you can refer to. What I'm going to share is the work that led to what I really want to get to, which is our California Right Meds Collaborative. So this is work that the Right Care family is familiar with. We received a round one Center for Medicare and Medicaid Innovation Healthcare Innovation Award, where we were able to partner with Ultimate Health Services to add 10 clinical pharmacy teams into their large network of PCMHs. They had, I believe at the time, probably more now, 40 plus patients in their medical homes. We were at 10 of them. We had a video telehealth team that provided care from USC to 2 of their locations that were either too small in square footage to host a full team or too small in terms of patient volume to warrant a full team on site. And our outcomes were all quadruple aligned, bottom line. Our intervention was comprehensive medication management, targeting high-cost patients, primarily the frequent flyers to the hospital, recent acute care utilizers. We developed an algorithm, 48 different triggers that would suggest gaps in medication-related quality or safety. These triggers included demographics, problem list, medications, vital signs, lab results, things like that, that in the end would give us these gaps, such as patients with persistent asthma who are not on controlled medications, systolic dysfunction, heart failure, no beta blocker, no ACE, ARB, those sort of things. And our intent was to, by using these triggers, sort of coach the physicians on what kind of patient would benefit from comprehensive medication management. And for the first month or two of the program, the majority of enrollees were triggered by the triggers or the acute utilization. But immediately after that, it flipped. Physicians got it, they valued it, and by far the majority of referrals came from the physicians. Again, we provided comprehensive medication management. We kept seeing these patients an average of 8 to 9 months, 8 or so visits for a typical patient till they reached treatment goal. And even when they got to goal, we trained our pharmacy technicians to be clinical support personnel, and they would check in every few months with the patient to make sure they remained at goal with a very simple yes/no checklist. If anything fell in the wrong column on that yes/no checklist, which by the way, Dr. Shah stole from Kaiser in many ways, the patient would be reevaluated by the pharmacist and potentially re-enrolled. So the lease was short in terms of making sure patients were being watched. This is our low-tech solution. Wish we had an app for that. So we enrolled about 6,000 patients, mostly just a few more women than men, say lots of Latino patients, good amount of hypertension and uncontrolled hypertension, good amount of diabetes, surprisingly pretty low rates of baseline hospitalizations. I think only a few hundred patients had a hospitalization the previous year, which we did not expect, and that does drive the ROI. And we used a very rigorous model for evaluating our outcomes, a propensity score match comparison with usual care patients. And I'm not going to go through every little detail, but here's an example of some of what we found. Usually within the first 45 to 90 days, most patients were able to get to blood pressure goal. Of course, at that time, it was 140/90. We know it's much more stringent now. When we looked at hospital readmissions, overall, there's an absolute difference of 16% in patients that were seen by a pharmacist and 33% when considering readmissions attributed to medications. We saw mortality differences in our patients. It wasn't a large number, but there was something there. And then very importantly, when we looked at the drug-related problems that we were identifying and resolving for this population, it was a pretty good number, averaged about 11.5 per patient, 67,000 drug-related problems. And what I want to point out here is whenever I discuss the idea of adding a pharmacist to the care team, to a health system or to a provider group, the response I get if there's any interest is, well, that sounds really good. We need help with non-adherence and polypharmacy. And what I point out is those are important, without question. But we've collected this data, meaning drug-related problems identified and resolved by pharmacists in the VA health system, in private medical groups, in safety net care, and the proportion of problems always comes out the same. The biggest issue that we identify is appropriateness and effectiveness of drug therapy not being optimized. And that means an optimal drug may not be being utilized for the patient, or a dose may not be appropriate or reasonable, or as I mentioned before, there are indications that are not being treated by medication, which should be. Still, there's plenty of need for non-adherence. You can see that in this pie chart. We're picking up adverse effects or potential adverse effects, the other 20% down below. And in many cases, patients are out drinking their diuretics, out eating their diabetes medications. But again, appropriateness and effectiveness is the biggest intervention. And as a result, when you look at what we did as pharmacists in this program, we more often than not added medications, adjusted doses of medications, or substituted medications than we did discontinue medications. So what that tells you is when you add a pharmacist to the care team, you're probably going to slightly increase drug costs, potentially. That could be offset if you optimize utilization of generic medications, but that should be offset by reductions in total healthcare costs if you're enrolling patients who are expensive to begin with. We administered a standardized survey on physician satisfaction. You can see that physicians are very happy with the services they received. The feedback we got from physicians was, well, we've never had a pharmacist in the care team, but we didn't realize how much we needed one. In fact, it was so good that physicians from the control sites tried to send their patients to the treatment sites, which would have ruined the study. So we had to get, at the time, Michael Hockman, who was over at Ultimate, to help intervene on that. Likewise, using a slightly modified CAP survey, HCAP survey, patient satisfaction was very high. We were told by somebody at Kaiser that the highest you can get is 9.6, and we were able to achieve that the first year and 9.7 the second year. We were told by the folks at Ultimate that they had the most unsolicited letters from patients about our program than anything else they've done in the past. So we were excited to hear that. So overall, we seem to hit a lot of the key value proposition values that Ultimate and in general healthcare is looking for. Lower healthcare costs for patients who are at risk of readmissions at baseline, better healthcare quality measures, better medication safety, physicians were happier, patients were happier. And something we mentioned previously is, by having a pharmacist manage 8 or so plus visits in a given year on behalf of a physician to focus on optimizing medications, that improves physician access. Now physicians have more time to do the things that they really want to do, right? And we clarify this with their medical staff. They appreciated that. That's exactly what the pharmacist brought to them, was more availability to manage those very difficult to diagnose, difficult to figure out patients and give access to more patients. So, with that background, let's kind of go into the ultimate question here. Here we were so excited to get this Healthcare Innovation Award. What was the outcome? What ultimately happened? Is CMS working on policies that will support widespread ability of comprehensive medication management services? B, did the FQHC partner for our program end up funding comprehensive medication management after the grant ended? Or C, none of the above? And yeah, if you're guessing, it was none of the above. Now, why would that be? I'll share with you some insights that we gained on this one. After the first year and a half of that CMMI project, all the round one awardees were invited to CMS to talk about their projects and presumably to learn about how CMS would manage any kind of sustaining activities to sustain the work. And at our meeting that we convened at, the first question, I kid you not, that the moderator asked was, okay, who wants to share how they plan to sustain their interventions? And it was quiet. I mean, this huge room with all these awardees didn't say a thing. And the responses were a bit, some frustration about why are you asking us that, right? So it became very clear that the intent was not to necessarily scale up any of the CMMI Healthcare Innovation Awards, but rather the awardees have to figure out how to sustain. The second, as we were ending this program with Ultimate Health Services, we were given a lot of feedback about how this really checked every box on what they were looking for, and that their intent was to continue the program. But with a couple months left, we suddenly got word that after more close scrutiny of the financial implications of this, they concluded that because we can't bill for a pharmacist, we just can't do this. And their proposal was to try to work out a hybrid model where there are 3 consultant pharmacists that would guide 7 PAs to continue these interventions. And that wasn't something that we were comfortable with. And I can tell you that today they've abandoned that and are now going back to trying to put together a pharmacist-based CMM program. But the bottom line is our team was left a little bit disappointed with the outcome. And after having at this point for about 20 years in my career, pretty much tried to sell comprehensive medication management directly to clinics, FQHCs, health systems with reasonable success, I concluded that this is never going to result in the numbers of people that need this work to benefit from it. It's just, you can't win this one clinic at a time. So we decided, let's try to pursue payers. Let's try to go directly to payers and come up with a solution where we can provide comprehensive medication management to their beneficiaries. And that's where we went with the California Right Meds Collaborative. So I want to give recognition to the team members in this program. These are all my overworked team members that put up with me. They're fantastic. And in thinking about this partnership, and I had spoken to several payers for many years prior to coming to this point, we had to think about things that I think are probably you all realize as clinicians. And that one is, especially working with the underserved. I spent 9-10 years on Skid Row. What you find is that patients struggle to come to clinic, and I didn't really think about that until I realized that some of my patients I saw on Skid Row were traveling 2 hours by public transportation to get to me, and they lived in LA, right? It's just difficult to get around. So it's not easy just to expect patients to keep coming back. And the other is sometimes we have the best ideas for patients who are underserved, but we don't necessarily connect with the cultural nuances of what works for them. And I saw that quite a bit as well in my practice on Skid Row. We need to make sure our solutions work given the patient's limitations in terms of just their struggles day to day, their cultural norms, things that can make all the difference in their outcomes. So in thinking about how we would do that, we said, okay, let's not think about embedding a pharmacist in every clinic, right? That may not make sense for a lot of reasons. Let's try to leverage this large network of pharmacies that we have out there that are available in the community. There are 4 times more pharmacies than Starbucks in the US, and that's not much different in California. Our goal was to create a network of these pharmacies, highly trained, very selective, that would provide comprehensive medication management in the neighborhoods where patients lived, highly accessible, providing culturally competent and sensitive care, because their staff is almost always aligned with the community they serve. If not the pharmacist, that pharmacy technician is almost always of the same ethnicity or culture as the patients they work with. So again, this, I think I've already said this, but there are many more pharmacies than Starbucks. And furthermore, and I am sorry I didn't put the citation in, but if you look at how often people show up in pharmacies, for seniors, it's at least once a month. For non-senior Medicaid, 2 to 3 times a month. That's a lot of face time at a place where they're already going. And I think that's key, right? Is we want to be able to provide care at places where people are already going. And if you recall the barbershop project from the late Ron Victor, I think one of his key selling points was most patrons on average got a haircut every 2 weeks. For the Medicaid population, we're talking about at least that frequency of face time. So one of the keys to making this work is we literally train our participants to death, right? Currently, we have partnerships with IEHP, LA Care, and Brand New Day. We have live learning sessions. They've been remote, obviously, for the past year and a half or so, that occur generally twice a year. These full-day learning sessions offer the opportunity for participants to hear about best practices at delivering comprehensive medication management, what they've done, how they've done it, the results that they got. And there's further opportunities to have where pharmacists or pharmacies at different levels of CMM maturity can get training commensurate with where they're at to advance them to the next level. And then in between these learning sessions, we have action periods. These action periods, as you might have guessed, include more training, right? We have lots of webinars. For a while, we're doing weekly. I think at this point, we're about every 2 weeks now. We do more on comprehensive medication management, deep dive into certain conditions. We do a very extensive CQI process. And I think all of us agree here that if you have data available, as Dr. Balmer had spoken about previously, you can really drive change. And that's what we do here. We have a data platform, which I'll talk about a little bit later, that collects info real time that we can share, we had been sharing on a weekly basis with our teams. So not only did our teams know how they were performing relative to the other team members, but the health plan knew exactly where everything was at. And the health plan, believe me, uses that data to either help teams, or in some cases, they've had to dismiss a couple of teams just because they couldn't perform well enough to their liking. We have sessions specific to social determinants. All the health plans have really fantastic resources they make available to their patients, and our pharmacists are key in making those connections. Culturally competent care, motivational living, shared decision making, all these tools, resources, skills that are essential to getting particularly underserved patients to their goals. We have one-on-one coaching, so there's a lot that goes on with our teams. It's not easy to be a member of this collaborative. So what are some keys that have made this work so far? One is that we stringently vet the participants in this program. So if the way that it works is there's 4 stages. The health plan identifies the area at which they'd like to see a pharmacy participate. Invitations are sent out to pharmacies in the area to complete a very extensive survey on their preparedness to offer advanced clinical services. This includes things like, have they done it before? What kind of clinical programs have they participated in? What are the qualifications of their staff? Do they have space, private space set aside to see patients? They have a decent waiting area, a parking lot, all these different elements. If the results come back where it looks promising, the health plan and we together do an on-site assessment, on-site survey to validate the responses, ask more questions, make more observations. And then if the health plan has available any quality data that they track, they then evaluate whether that quality data is consistent with what looks like a high performing pharmacy. They pass those hoops, they get in the program. We're fortunate to team with Dr. Tony Kuo and Noel Bergen at the LA County Department of Public Health on a CDC 1817 wellness grant that funds the work in LA County. Irene, thanks to Dr. Shah, is now our official clinical platform partner. We reviewed every major platform aggregation company available that works with pharmacy, and Irene is fantastic. They not only are very good and effective at pulling data from all different sources, whether it's claims or clinical, but they also, to tie back to Dr. Shah's presentation, are very good at advancing machine learning to produce data-informed AI recommendations on everything from health to social determinants of health to help guide and assist the pharmacist in being more effective, and have had some tremendous outcomes demonstrated in other states like Oklahoma. As I mentioned to you before, that clin pharm tech is really important. Just like physicians probably couldn't survive well without a medical assistant, the clinical pharmacy technician does that for the pharmacy team. We train through a program that we developed through our CMMI grant program. We certify pharmacists to be, technicians to be clinical. And as a result, what we saw was in our teams with a clinical pharmacy technician, they were able to see 50% more patients per day. So very efficient. Any process, but I learned from the late Dr. Ron Victor that the QI I grew up with in the VA was experience with asthma, some probably 15 plus years ago with Blue Cross and sharing, where we did something very similar. Blue Cross came to us and said, we'd love to target Medicaid patients that are frequently being hospitalized or go to the ER for asthma. So they geo-mapped their hotspot areas. They invited pharmacies to participate in those areas. They paid for the training, which we provided. We certified them. And then they basically sent them these high-risk patients. And I was not quite sure if this would work, but as you can, for the first almost 400 patients, you had about 70 to 80% reductions in ER visits, hospitalizations, inpatient days, and costs across the board. So it was quite effective, and we're using lessons learned from there. And as I mentioned before, probably the most important thing is it's always about money. There's a value-based payment model in this program where the pharmacies are paid modest fee for service and really only get fully compensated when they reach the thresholds for the different diseases that are being targeted by the health plan. So I'm going to share some interim results from LA Care Health Plan. This is the remarkable team that we get to work with over there. They're all just amazingly progressive and smart, bright people. Couldn't pick a better initial team to work with. This is what their initial pilot looked like with the pharmacies. You can see that they intentionally try to get a pretty broad spread of pharmacies located across LA County for the pilot. But really importantly, they have paired every one of these pharmacies with at least one FQHC. This isn't a complete list, but the idea was to identify FQHCs that have some patients that could benefit potentially from CMM because of chronic disease control rates that could use improvement, and to set up these partnerships so that communication would be ideal. There'd be the opportunity to create a collaborative practice agreement that would allow the pharmacist to do more on behalf of the physicians and partnership with them, and then get to the electronic health record sharing, which some of our sites have and others are developing at this point. For LA Care, as with any health plan, frankly, when I introduced this program, I said, what would you like to start with for the pilot? Do you want to go after some of your high acute care utilizers like heart failure and asthma? And they said, no, we'd like to look at uncontrolled A1C as the target population. And I haven't seen that much for a pilot, just because it takes a while to get data and you don't necessarily recuperate costs for this population quickly. And upon further questioning, the issue with LA Care is they've just had a very difficult time moving the needle on improving A1C. And according to their senior leadership and their board members, they would be very excited about a program that would do that. So I'm not arguing when a plan tells me it's important to them. That's what we went after. So the proxy was A1C above 9%. Remember I mentioned the bonus payment? That bonus payment was paid off when A1C was at least less than 8%, sometimes lower, of course. Blood pressure is at least 140/90, usually less than 130/80. And statin is on board if not contraindicated. All those had to be in place in order for the pharmacy to receive that bonus payment, which was the bigger payment versus fee for service. Now, I want to qualify something here, and this is only 5 months of reporting from the day we started to 5 months. And why would we stop at 5 months, knowing that it takes 8 to 9 months for your typical double-digit A1C patient to get to an A1C target? It's because LA Care was interested in seeing where this program was going in order for their senior leadership to bless it and continue it. And I thought, okay, great. We launched in the middle of the pandemic, started literally right after Thanksgiving. This is a time when it was really hard to track down physicians. Most of our teams didn't have a CPA, so we had to ask permission or to make changes and such. So I was dreading it, frankly. I didn't know how well it would work. So here's who we looked at in that initial pilot pool. Over a couple hundred Medi-Cal members, lots of underserved communities, lots of minorities, average age 53, few more females than males. About a quarter of patients had uncontrolled hypertension, only 42% on statin at baseline, about 11.5 A1C at baseline. And what you see is in this 5-month period, we got about a 2.5 drop in A1C. I was thrilled. I thought, well, that's actually not bad. We have ways to go, of course, but this is 5 months. So I was, again, quite impressed with how the teams have performed. Now, this wasn't all by luck. As I told you before, we provided them a de-identified report card almost every week so they knew how they were progressing. And what this shows you is more visits, better impact on A1C, which is what we like to see. For blood pressure control, these are the different categories of blood pressure levels. You can see the red bars baseline, the yellow bars at the 5-month period. So you're seeing a shift in control to the left, which is what we want to see. And similar to the other chart, versus this one, we got about a 16-point average reduction in systolic blood pressure, which is good, but we'd like to see something closer to 20 plus, and we're getting there. And as I showed you with that previous chart, more visits generally associated with better blood pressure control. Now, there's a formula that we sort of prescribe for managing hypertension, which is we should be able to get pretty much any patient with uncontrolled hypertension to goal within 45 to 90 days after about 6 visits. And this is based on our own work as well as the work with late Dr. Ron Victor in the Black Barbershop program, where pharmacists went to barbershops to manage high blood pressure. However, those numbers are when you have a collaborative practice agreement. And in most of these cases, we did not yet have one. So we had to create, based on our experience, based on evidence, what are some ideas to move the needle in terms of prescribers and to get them to make changes that are needed. And so you can see on the left-hand side of this infographic we created, we said, look, you have to provide not just the data on the blood pressure measurements, but also the evidence, the guidelines that support why you're making this recommendation. In some cases, physicians just aren't aware that they should be making a change. And so providing this information as objectively as possible, rather than you saying it's your opinion, is going to go a lot further. This may seem odd to you, but that second bullet point under the first one is because sometimes physicians ask the question, well, how do I know you know how to measure blood pressure? So just make sure they know that you're using validated equipment, you're following AHA, ACC standards. And then probably really importantly, physicians, as we just shared, do not have a lot of time, especially in the primary care setting, offer to provide the follow-up for that patient. Everything from the follow-up visits, the plan, what you're going to do, how often. If you do that and they take you up on it, then you'll start to establish that trust between the physician and the pharmacist. Another intervention that we suggested is more face-to-face time, right? So remember, we paired pharmacies, with FQHCs at least once a month. Go to their medical staff meetings if they'll invite you, which is what they all have. Give them an in-service, give them an update on what's going on with the collaborative with their patients. Some of our pharmacies are actually sending pharmacists on site once a week to these FQHCs to provide face-to-face care. side by side with the medical staff. So these are ways to at least get more opportunities to engage, to build trust, and to consult on some of these patients where we're not able to get physicians to make changes at least right away. Leveraging a respected authority that I used to say, Dr. Ron Victor said, and it got doors open for me everywhere. But there are other influential people at each FQHC that could be the right person, whether it's a CMO, another PCP colleague that's part of the program that loves it. And then last but not least, tie it to the QI, the P4P programs. But the right-hand side, even though I only have 2 bullet points, is really very important. We found that by empowering the patient, by teaching him or her about the importance of the disease state, of controlling it, what their medications do, what their goals are, their targets, they become their own self-advocates. They share the blood pressure control logs, the blood glucose logs with their physicians and ask for an action. And that's oftentimes more effective than us asking for an action. And then the last one on the bottom is, it actually worked well during COVID. The offer, which some of our teams have done, to accompany the patient on a virtual appointment with the physician. So for example, one of our pharmacies offered to have the patient come in for a video telehealth appointment and accompany the patient at that appointment with the patient's permission, of course. And it worked very well to have that dialogue, that conversation with the PCP. On statin utilization, as I mentioned before, the baseline was only 42%. It's up to 84%. So, something that you would think would be fairly ubiquitous, use of statins, really was not in this population. Now, at this point, I'm going to share a video, and I will probably try to shorten it a little bit, but this is a patient who received care within the collaborative, and I thought it was worth showing. Normally I invite a patient to attend. I think it's a little complicated to do this in the Zoom format, but I think you'll be quite interested in what she has to say about her experience being in the California-Reitman's Collaborative.
Good morning. My name is Dana Prince. And when I found out I was a diabetic, my heart was hurt. But I've learned to live with it. It's been a struggle. It's hard you have to read everything on the boxes to make sure that it's not hitting sugar or it doesn't have no sugars in it. And I've been probably a diabetic 20 plus or more, and it's been a struggle, and I've been going up and down on my sugar has been changed. First I was on pills, and now I'm on insulin. I've been taking insulin 3 times a day, and poking yourself and pricking yourself hurts, but I've learned to deal with it. I had this doctor before. I have Dr. V. I can't pronounce his whole name because it's a long name. She wasn't doing nothing for me. She was checking my sugar and sending me on my way like it was the thing to do. And then when I got with Dr. V, he started talking more about keeping my A1C down. And 3 months ago, I found out my A1C was really, really high. It was a 9.6, and that's really high. And he got me scared because he said it's going to mess with my liver and my kidneys. I wasn't eating right. I would eat fried food. I would eat 2 or 3 tacos when I know that I shouldn't be eating it, but I ate it. Then when I got with him, he put in my mind that you don't want to go to the hospital and have feet amputated or legs amputated. And when he told me that my A1C was high, I really got scared when he said it's going to mess with my liver and kidney. I want to be in this world for a long time. I want to see my grandbabies. I want to live a good life. So he called this program, and they called me, and Crystal came into my life. When Crystal came into my life, I was like, can't nobody help me. I'm just unhelpable. But Crystal brought to my life that I can help you. She said, Dana, you have to change your eating habits, portion them in moderation. And I'm like, okay. I'm so used to eating 2 tacos and a good healthy plate, you know. So I have changed my eating habit. I eat more vegetables. I used to didn't like cauliflower. I never knew how cauliflower was, but I tried it and it was delicious. Can't get enough of it now. And that's thanks to Crystal. And she told me that my insulin might have been too much some days and just right on some days. I'm taking 70/30 insulin. That's two different type of insulin mixed together. And I'm taking that, and I was taking 30 in the morning and 30 in the evening. And sometimes I get the low sugars, and that got concerned with me because I'm in the house by myself at night when my daughter's at work. And it kind of got me scared that if my sugar goes down, who's going to be here to help me? So Crystal said that she lowered my insulin down to 20 in the morning, and I'm taking 20 in the evening. And that's doing good. But some days I eat some type of food is not enough. And if I go to walk my daughter to work and I come home and check my sugar and it went down to 68, and I'm like, why did it go down to 68? For what? I I was full. You know, I wasn't stuffed, but I was full. And that's because I'm not eating enough protein. I have to eat some protein to keep it in line, to keep it together instead of going up like this or down like this. I have to keep that going. So I'm trying to eat more protein. I got to get used to what is protein and what is not so I can eat more protein. So Crystal has been a heaven sent to me. She has helped me so much. Like I said, my A1C was a 9.6. 2 months ago, I checked it. Crystal checked it. It might have been a month ago. Crystal checked it, and it was 8.4. I was so happy. I'm like, oh, wait, I'm doing good. Let me keep doing it. Yay! Go, Dana, go, Dana. And I was so happy with that. And I'm so happy with the results that Crystal is giving me. I want to keep doing it and makes me want to do it even more every day. And every time I video chat with Crystal, I like seeing her face. I like, I believe in the stuff that she's telling me to do. So I'm doing the stuff that she's telling me to do. Crystal is amazing. This program is amazing. And I hope they don't never take it away because you don't never know when the next person might need it, might be in the same place that I was in that, oh wow, I can't do nothing. I've been trying everything. But if you just stop and think and step back and change your eating habits, your sugar will go down, your A1C will go down. It's not going down as fast as I want it to go, but it's going down. And I really, truly am happy on the results that Crystal been helping me with. And she got me this machine that goes on my arm to check my sugar and stop pricking these fingers because it hurts. And it's been amazing on it. It has to get used to me because sometimes it's one is saying high and the other one is saying low. But lately it's been registering it together. And I love the machine on my arm because it stops my fingers from hurting. Crystal is amazing and the program is wonderful. Y'all keep doing a good job because I love it. And I've always, anything y'all need me to do, I will do because I listen to everything Crystal is telling me and I feel good. And I walk during the night. I leave here at 10:30 and I come and walk my daughter to work. We walk slow. She walks slow. I can't walk slow, but I walk slow going with her. And me and my dog, I have a pet bull. Her name is Ladybug. We walk, I speed walk with her. We be gone. And we get home in 5 to 10 minutes, no later than that. It's amazing. I just love it. I enjoy it. I can't say enough of the program. It's just amazing how somebody can come in your life and change it. And when I needed it, they wasn't helping me. And now I have so much help from Crystal. another lady who's helping. I have so much from both of them. They are amazing, wonderful women that if somebody who needs them to come into their life, they will be amazed with them too. I really truly appreciate this program. Thank you so much. I just needed that push to say you can do it because you saying to yourself you can do it, but a person needs to hear from another person saying, Dana, you can do it. I believe that you can do it. And Crystal has gave me that, and the program has gave me that push to say, well, I can do it. Stop saying you think you can do it. I probably can't do it. If you want to live longer and be successful in your life and grow old, you have to put your foot forward to do it. I didn't say it was easy. It ain't easy, but you have to have that trust and that willpower and that person that is helping you to help you go through your journey. And it's been a good journey that I don't want to never ever let it end. It's been a beautiful journey that I will recommend y'all to everybody.
So I keep forgetting how every bit of what she says is so good. So I'm sorry I paused it a few times. And Hattie pointed out that, yes, I probably should have given more context. She was talking about one of our teams. Crystal is one of the pharmacists at our team in Pomona, and she'd worked with this patient for quite a good number of months. And as you can tell, established just a great relationship, great trusting relationship. I was able to get through some of the important points that, as the patient said, made all the difference in her outcome. So yeah, I agree. The comments are coming in. It was a great testimonial, and this is one of many. Right, we have patients who experience this for this first time, sharing very similar types of testimonials. Yeah, Crystal deserves an award. Absolutely. I think, to be honest, Lorianne, many of our team members deserve an award. Let me put it this way. This was not an easy program to be part of as a pharmacist. You had to be committed to a value-based program, which paid very little upfront in fee for service. And basically, it required these pharmacies to subsidize much of the care that they provided to achieve the outcomes that you've seen. So my hat's off to our team members, our participant pharmacies, and our team that takes care of them. So in terms of where we're headed, next steps, this is sort of just a checklist of all the things that we've been able to complete or have ongoing so far. I've talked about just about all of these. The two yellow bars I just want to spend a minute talking about. We're in that phase now where we're spreading awareness and engagement in the California Right Meds Collaborative. And that means we're reaching out to health plans, other payers, to see what their interest might be in participating. Now that we have some early pilot data and we have a process that works, and we can do all this by Zoom, right? We were able to show that as well. And we're getting some really good interest, probably 6, 7 plans between San Diego and up in Sacramento that have expressed interest that we're reaching out to at the moment. The other is, I know, excuse me, Dr. Jessica Nunez de Ibarra is here from the California Department of Public Health. She and her team have reached out and, well, haven't reached out. We've been working together forever, right, Jessica? And created a great opportunity to collaborate with her on a post-stroke comprehensive medication management program, basically targeting patients immediately after they're hospitalized for stroke to get CMM and to manage everything from high blood pressure to other risk factors for repeat stroke. That's going on now with IHP as the health plan partner, and so more to come. In that program, I should mention that Dr. Nunez de Ibarra was very interested in trying to see if we can get a community health worker involved. And the economics made it very difficult, but what we're leaning towards now is training those clinical pharmacy technicians, giving them some skills as CHWs to fulfill that role as a part of their farm tech work, which is not 100% novel. It's been done in other states, but not in this kind of underserved minority group that we're targeting. Some other quick updates. Some of you know this on the call, but the California Department of Healthcare Services is in the process of proposing a medication management benefit. What that means is they are identifying high-risk patient populations that can be enrolled for medication management services provided by pharmacists. And in their proposal, at least at this point, the payment is a fee-for-service model. And that came about in large part because of an effort by the California Drug Utilization Review Board. They had sent a letter to DHS requesting that CMM be a mandatory benefit, in part related to the centralization of the pharmacy benefit management within the state, the Medi-Cal RX. So that's something to look forward to. Not actually very far away. Their timeline to implement this and actually get it operating is this calendar year. The other is hats off to Liz Helms from the California Chronic Care Coalition. She connected with friends at Cover California and created an opportunity to promote the idea of adding comprehensive medication management as a benefit for Cover California beneficiaries. We had a meeting a couple weeks ago with Cover California leadership, shared this collaborative with them, and the response was very positive. They said everything about what we're doing checks the boxes and all the goals that Cover California has. And at this point, we were given the offer to pitch the Cal Right Meds Collaborative to all the plans that are part of Cover California, and they would in turn work on some incentives to incentivize the participants or the health plans to participate. So I'm going to close because there are questions. I see that Hattie is giving me a cue that I should start answering some of those. This basically summarizes what I just said. We're looking for more partners, payers, et cetera. So please let us know if you know anyone that might be interested. I will just say that although we'll all look back at 2020 and say, gosh, we don't want to go back there again, let's admit that 2020 was the innovator in telehealth and gave us this opportunity to connect with people across the nation in the California Right Care Initiative meeting. So that's been a huge plus. And last but not least, for anyone except those of you that fit this description, I'm sure you'll be really excited tomorrow when California lifts some of their restrictions. So thank you. And I will stop sharing.
Thank you, Steve. And Bob, a couple of final words.
Yes, Steve, thank you so much. Unfortunately, I have another Zoom call at 2 with one of our sponsors, so I'm going to have to jump off. But Hattie has graciously agreed to oversee the question and answer session. And I think it works best if people will use the raise hand function because, among other things, it's easy to identify on our side and it actually cues people in order. So Steve, I'm sorry I'm going to miss the question and answers, but thanks so much for a great presentation.
Oh, thanks so much, Bob, and have a great rest of the day. Really appreciate it. Thank you.
I do want to point out that we have some newcomers with us, including someone that I met on a Zoom with the Harvard alumni entrepreneurs, Kristin Hayes. And because she's not a panelist, I'd like to go ahead and have you answer her question first, because she's a newcomer and she's excited about this. She is an angel investor, so you might want to consider catalyzing something together. So she asks a couple of questions. Are you primarily using independent pharmacies or the big chain pharmacies? Do you see any difference between the chains and independents in terms of compliance?
Yeah, it's a great question. And I'm sure it's very much a leading question as well. So all of our participants currently, Kristin, are independent pharmacies. They can jump on board to something like this immediately, right? Whereas with all the chains, we have one chain in particular that's very interested, and we think they're fantastic. Getting corporate approval is so difficult and challenging. So we've basically gone about 1.5 years back and forth with their corporate office to try to get permission. When they finally took up the question, they came back with just restrictions. And so for now, we don't have a go-ahead. We're still hoping that it's alive, but it's difficult to get stores, isolated stores to participate in something like this, just because the corporate office just has a lot of risk issues. So we've not been successful yet. We're still hopeful. That chain is still, like I said, hasn't given up yet. Not that it's a large national chain, but Rayleigh's in Northern California is very excited to join and is ready to go. They have 70 pharmacies up in the NorCal area. Okay. Hattie, do you want me to go through the chat questions? Would that be the next step?
Well, we also have someone who was one of our early Right Care leaders, Professor Helen Halpin, who's coming back to us in California. She's been away for 12 years living in France and in Greece. Welcome, Helen. Do you want to go ahead and express your perspective and your question? You are muted. You are muted, and we are so thrilled that you're back.
Thank you so much, Hattie. And it's wonderful to reconnect and to have the opportunity to participate again in this amazing initiative. So thank you very much. Having lived in a single payer system for the last 12 years, I've learned a great deal about what's both possible and perhaps not possible under our system here in the US. And I just wanted to share just a little bit about the pharmacist as part of the primary care team, because that's the model under which I received care for 10 years in France and for 2 years in Greece. And in both places, the pharmacist, your local pharmacist, and you chose who your pharmacist was, just like you chose who your doctor was, they were intricately involved in your team. And I was as close to them as I was to the physicians, and neither the pharmacist nor the physician ever hesitated for a minute to pick up the phone and call one another to consult. And it made me feel so good about the quality of the care that I was getting with both my MD and a pharmacist very involved in making decisions about my care. The other ways it was integrated that I thought were really important is that you could only get a prescription for 3 months. And before they would renew your prescription, you had to go back to your primary care doctor to have your disease managed. So for me, I have high blood pressure, and I actually had a heart attack in France. I was diagnosed as having cardiovascular disease as a chronic condition. And in France, once you're diagnosed with a chronic condition, medications and treatment for that condition are free for the rest of your life. So there is no economic disincentive to taking your medication, to going for your visits and having your disease managed, or even hospitalization. I think that it worked because in those systems, both the physicians and the pharmacists were salaried. So there were no economic disincentives not to cooperate. And there was every incentive, being the health status of the patients, to cooperate. So the incentives were aligned in terms of providing the best care to the patient. And honestly, listening to your talk, it occurred to me that Kaiser perhaps can really implement something like this. And it sounds like maybe they have, because they're the closest thing we have to a salaried single payer system. But it's hard to imagine how we get this to really work and to have the pharmacist really become an advocate for the patient in conjunction with the physician under the current fee-for-service model. So that's our challenge.
Well, that's really well said. Makes me want to move to France. Thank you for that. Well, you're absolutely correct in that, as you said, Kaiser's been doing this, integrating pharmacists into their care team for decades, for 4 decades now, because they've shown that outcomes improve, their quality scores improve, patients are healthier. The misaligned incentives in our healthcare system just make it very complicated outside of a closed system. But I think where we started to see some opportunity is where CMS rolled out all sorts of different value-based incentive programs. And as I said before, we were really fortunate in that I worked with HRSA back in the late, about 2006, 2007, on a national collaborative to promote pharmacists in the care team. And one of the people that led that collaborative went to CMS. He ended up being the director for quality improvement and innovation, Dennis Wagner, and he almost single-handedly changed some of the culture and expectations of what pharmacists can do. So many of the incentive programs that developed were largely spearheaded by him. And he said, I'm very consciously thinking about making sure that these incentives incentivize providers to add pharmacists to the care team in ways that are meaningful, that actually produce value, that can then be reimbursed. So no easy solutions. I think what we've done with our health plans was our best attempt, right? Create a value-based payment model where the plans don't feel like they're just shelling out fee for service and hoping things get better. They only pay if things get better. And likewise, the pharmacists really don't get paid well unless they do well. So at least there's those incentives built into it.
I'm curious though, why is it the responsibility of the pharmacist for the outcome?
Well, because if they want to get paid, then they need to deliver a good outcome, right? And I'll quote someone who I think might be on this call right now. I won't name her name, but someone from a major health plan in California, where we were talking about their potential engagement in the collaborative. What she said is, if we pay for this comprehensive medication management in the same way that medical care is generally paid for, it's never going to work. We're going to end up spending all this money and not knowing if we're going to get the value that we want. So they really liked that we incentivize the teams to perform to get paid.
Okay.
And I think that's the only way moving forward we can scale this up.
Thank
one of
you.
the few ways.
But another question, which is related to the data behind me. So you see in the dark blue that we dropped in our first pilot community, we were able to drop acute myocardial hospitalizations for men faster than the state quickly. But in the aqua there, you see we dropped the heart attacks much faster for women. And it just strikes me that women often don't get the preventive care that they need. They often are in the pharmacy though. So I would love to hear your thoughts on how we can yield more out of that very regular touch point that women have, especially given what you're really seeing in that aqua slide is that the physician community actually had very little awareness of women's cardiovascular issues at younger ages. So by raising their awareness, and I think pharmacists can do that in those regular touch points, might we be able to better reduce women's cardiovascular disease? Not that I don't want to reduce everyone's, but since women tend to be the family caregivers, I think it's a special opportunity.
Well, I think Dr. Barry Mertz really made it very clear that we have a long ways to go to improve health outcomes for women. And so first observation I'll make, Hattie, is when we've objectively analyzed data with health plans and looked at where the gaps are in terms of medication-related needs, more women come out, right? Both this program and the Ultimate program showed that there were more women enrolled than men. So that itself is good news. But to your point, I think you're absolutely correct. Who goes to the pharmacies on behalf of their families to pick up medications, to get advice from the pharmacist? It's the women. So there's a tremendous potential opportunity that we should be leveraging to have women get screened, get advice, get guidance from pharmacists. And by the way, there are more female pharmacists than male pharmacists. So there's a nice opportunity to match up genders and have women counsel women on the importance of taking care of themselves and guidance on evidence-based therapy. So I know that when we met last time with Dr. Barry Mertz, and the question was coming up, where is the barbershop equivalent for women? I think the pharmacies could do it because they do have that much face time.
I do also want to point out for those who are new to our program that about this time last year, Steve Chen helped organize a presentation and help facilitate Health Partners Minnesota, describing their incredibly effective program managing hypertension by pharmacists titrating medications over the phone, receiving the data through Bluetooth home blood pressure monitoring. I think for those who are looking for a value-based model that has proven itself over a very long period of time, their work was first published in July 2013, first week of July. I remember because it was July, I think it was July 3rd, and it was like Independence Day for pharmacists. And I don't mean to test you, but you are a professor, Steve, and you might just mention a little bit about that top line and whether you're seeing that spreading anywhere, because with about 25% more patients quickly in good control for blood pressure, I think that should be a national model.
Absolutely. The Health Partners program was incredibly impressive. I remember when it came out, Hattie kept saying, "Take it to the bank." That was the quote that she took from the editorial about how helpful this was. Basically, it was remote management of hypertension by pharmacists. And to your point, Hattie, there were significantly better controlled blood pressure early on and over the course of time by having pharmacists intervene. Their time frames remarkably identical to what I just said. Generally speaking, patients got to goal within 45 to 90 days of enrolling in this program. And if you remember, Hattie, the most recent publication from that group was that they saw a 50% reduction in MACE in patients who were intervened by the pharmacist versus not. So,
you know, the rule against acronyms here, right? Because we're not
major adverse cardiovascular event. Sorry. Yeah, this is my apologies. So the question you're asking is, are we seeing that adopted? Absolutely. I can tell you that Inland Empire Health Plan, for example, is about to embark on major investments in technology to support their patients that need better management of their chronic diseases, including smart blood pressure monitors, smart scales, smart blood glucose monitors. Brand New Day has always done it. They've been ahead of the game, and they'll bring those as well into the work of the pharmacist. So yeah, definitely seeing more of that because it's becoming more available at a more reasonable cost. Yeah, so we're excited to see the work of health partners roll out to other places.
You know, I was interested in your patient testimonial where I think she was talking about the lifestyle Libre that
Yes.
Professor Ann Peters presented to us in Los Angeles
Yep.
on how the graphics, et cetera, assist pharmacists actually probably primarily in managing care. Can you talk about how that's working in this program?
Yeah, well, for patients who have multiple or require multiple daily injections of insulin, most of the plans will allow them to qualify for getting the Lifestyle Libre monitor. And to her, as you heard from her, it saves her all the finger sticks. It isn't all that easy and simple, right? Because you do have to match up your finger stick levels with what you're getting from the interstitial testing with these monitors. They don't match one to one. There's a bit of a lag with glucose getting into the interstitial fluid versus the blood. So you have to account for those things. But once you figure out the correlation, it's really remarkable how well patients can see, gee, I snacked on that cinnamon roll after lunch. Whoa, look at my sugar, take off, right? And so they start to learn what are the foods that trigger their blood sugar postprandially, especially what happens when I exercise even a little bit after eating. It really nips the blood sugar and brings it down nicely. So pretty remarkable tool for many patients and very much excellent feedback that the patients can then react to. So we've had a lot of success getting patients on the Libre in our program.
I see that our chairman has rejoined us. Dr. Balmer, did you have a question for Dr. Chen?
Yeah, Steve, great. Thanks for that presentation. The thing I was looking at is pharmacists versus farm techs. And farm techs, we can supply at about 1/4 the cost of a pharmacist. How many farm techs do you think you as a pharmacist could oversee? Because that would allow us to bring the cost down for scaling this up.
Yeah.
So
Yeah.
do you feel comfortable a pharmacist can oversee 2 farm techs or 5 or 10 if we really try to in-service the farm techs as being their advocates in managing these patients?
Yeah, I can. That's a great question, Bill. I can tell you, practically speaking, as a preceptor of students who essentially function as farm techs, I can easily supervise 3 students that are providing comprehensive medication management. However, the law says otherwise. It's generally a 1-to-1 in pharmacy law, which has been somewhat modified for COVID because techs, as you probably know, can also give the injection. But I don't see that as being any kind of necessary long-term change. It would be great. We are advocating for it. Lorianne DeMartini, the CEO for the California Society of Health System Pharmacists, actually has a question related to that, talking about, when we have pharmacists, farm techs providing these sorts of services, are there some conflicts with the board in terms of scope of practice? Lorianne, I think you know that there was something recently circulated with the board because the board had been asking that very question and thinking about clamping down on the role of farm techs. And the simple bottom line is it would be like taking away your medical assistant as a physician, right? We're not having techs do anything dangerous. They're just collecting information. They're not processing it necessarily in ways that they're not trained to do. Really nice response from a attorney pharmacist to the board about some of their concerns, which I hope will mitigate them. Any other questions? Oh, Hattie,
Dr. Chen, this is Joe Sky from Travis Air Force Base. I know we've talked about this before, but I think I'd be curious to just ask your observations on the advantages of pharmacists, at least in the practice that we've had here, where they can spend more time with patients, is that they can actually more precisely titrate blood pressure medications and actually get better results often than the primary care docs. Do you still think that that is something to strive for, or do you think we're trying to replace traditional providers?
Yeah, great question. It is something to strive for. It will never replace traditional providers, right? The way that we describe it in setting, and I came from the VA, so I have an idea at least with how military medicine is managed. The idea here is this is pretty much a capitated population, and if it takes typically for metabolic syndrome patients 8 visits over the course of 8-9 months to get the treatment goal, receiving comprehensive medication management, it would allow the physician then to only have to see the patient a couple times a year, while the pharmacist is titrating, managing medications, or in the test results, responding to those test results, so the physician doesn't need to. I don't know of one physician who would argue that it's a very helpful service, something that allows them to have more time to see more patients that are struggling to get access to them anyway in the first place. So I don't think it in any way replaces the physician, the PA, the NP. It fills a gap. It fills a gap that's been absent in the healthcare system in many healthcare systems that I think could make all the difference for the most challenging patients that we serve.
Thank you.
Thank you.
Well, we are about 15 minutes after the hour. Does anybody see any questions that haven't been answered? I want to just really thank the leadership of this group. It's absolutely amazing. Today is our 289th University of Best Practices, and we're at over 300 right care meetings because we started meeting statewide prior to that. So bless you all. It was great to have a couple of our old timers rejoining us. And we'd like to invite you to be with us for our next virtual University of Best Practices, which will address telehealth implementation for adults with type 2 diabetes and or hypertension as innovations are occurring at the California Community Health Centers. That will be on Tuesday, June 29th from 4 to 6 p.m. And with that, I'd like to give it to Chairman Baumer to wrap the meeting.
Well, we certainly want to thank Bob for arranging the program today and our 2 excellent speakers, new innovations in technology that will get us there, and Steve for presenting perhaps new utilization of perhaps an underutilized process of pharmacists in our healthcare system. And I think both of those could provide more personalized care, more precise care, more precision medicine as we move forward. And hopefully our society and our reimbursement policies can be flexible enough to allow these new opportunities to develop. We look forward to a lot of new opportunities and information. And again, congratulations to the founders of Right Care Initiative for their dedication, hard work over the last decade and the results that we've gotten. And we look forward to new information and new programs, and clearly a bright future as we have better innovations, better technology, better utilization of our healthcare system, and perhaps better suite of capability for treating cardiovascular disease, with our ultimate goal of getting to 0 cardiovascular disease. prevention is always the best way to handle cardiovascular disease. And we will not consider ourselves successful until we're able to get that dramatically down. And 20 and 30% reductions are great progress, but we still have a fair amount of residual disease to deal with. So we look forward to future challenges, and we feel comfortable that the group that has been put together will be able to adapt to these challenges and overcome them in the future. So thank you everyone for joining us, and especially all those participants today. We look forward to the next program at the end of this month. And for now on, have a great afternoon and enjoy your leisure time, making sure that you include some exercise in the program today, since for some of us, we've been sitting for about 6 hours so far. So thank you very much, and we will see you at the next meeting.
Thank you, Steve, for
Bye-bye.
introducing us to Dr. Shah.
Pleasure. You're fantastic. Thank you.